Thank you, Karen. I'd now like to introduce Professor Jacqui Close. Professor Close is a geriatrician at Prince of Wales Hospital in Sydney and Clinical Director of the Falls, Balance and Injury Research Centre at Neuroscience Research Australia. Her primary research area is falls and injury prevention and management, with interests extending from risk factors and interventions to prevent falls to the impact of falls and injury to health service use and the way in which health services are designed to prevent and manage falls in older people. Jacqui is co-chair of the Australian-New Zealand Hip Fracture Registry, housed at Neura, and a past president of the Australian-New Zealand Society for Geriatric Medicine. Today, Jacqui will be presenting on dementia and preventing falls. Thank you, Jacqui. We can see your slides, just to go to presenter mode.
Lovely, thanks very much, Lorraine, and these are certainly unusual times. Unlike Karen, I'm not in my bedroom. I'm at work because even with a pandemic, older people are still falling over and breaking their hips. Interestingly, however, I think many of us think that we're seeing fewer hip fractures. I'm certainly not proposing that a pandemic is an effective fracture prevention strategy longer term. And what we don't know at this point in time, of course, is what happens when everybody comes out of hibernation, where they've been almost certainly functionally declining through limited physical activity during this pandemic. And we'll work out in years to come the impact in terms of falls and fractures. So for me, I'm focusing on dementia and trying to prevent falls in this population today. Karen's already highlighted in terms of our Australian population. We sometimes hear this derogatory term of the silver tsunami, but the reality is we should be celebrating the fact that Australians are living longer. More people are living into old age, and they remain healthy and active contributors to our society and play very pivotal roles in terms of childcare and still contribute significantly. So that the reality is that we are a successful aging population. That said, we know that there are more people now in Australia living with dementia, particularly when you consider residential aged care facilities, where over 50% of people in our facilities will have a diagnosis of dementia. That is the reality of our current society. I've had this slide for years and I've seen no reason to change it because the data and the evidence hasn't changed either. So we know that when you consider people with dementia, their falls rate is double that of people who are cognitively intact. They're more likely to fracture. In terms of risk factors, they're more likely to be on centrally acting medications, which have been a long-standing known risk factor for falls. We know that when people are admitted to hospital with dementia, 14% of those admissions are actually fall related. And we also know that when people with dementia do get admitted to hospital for whatever reason, they have poorer outcomes. Now, trying to prevent falls in people with dementia is not new. This is probably the first trial in 2003. So this was Fiona Shaw's work from Newcastle in the UK. And there'd been a number of trials, multifactorial trials published, including work from the emergency department, suggesting that a multifactorial approach could prevent falls. And what Fiona tried to do was take what had been shown to work in a cognitively intact population, apply it to a cognitively impaired population and evaluate whether we could prevent falls. And when you look at this particular population, the first thing to note is most of them were residents in residential aged care facilities, and they certainly were cognitively impaired. So MMSEs of 14 and 12 in the intervention and control group respectively. So they certainly managed to get an impaired population. So did it work? Well, it doesn't matter which way you look at the outcomes, it didn't work. So just lifting something that's been shown to work in a cognitively intact population and apply it to impaired population doesn't appear to be effective. What we also know, and again, this paper is 8 years old now, but I don't think things have changed substantially over those 8 year period, over that 8 year period, is what we know is people with dementia are also less likely to be prescribed treatment for osteoporosis. We have a heap of evidence out there that tells us that we can prevent fractures by treating osteoporosis, yet people with dementia are significantly less likely to be offered those treatments. This is Morag Taylor. This was her, I think, probably in about 2007, 2008. So she's aged a little bit since this picture. And she has spent the last 10, 12 years of her life studying falls in older people with cognitive impairment with me. So a lot of what I'm presenting is actually some of her PhD work. And Morag set out to have a look and say, well, what is it about people who have cognitive impairment and dementia? What is it about them that increases their risk of falls? Is it that they are physically more impaired, or is it the cognitive aspects that make them more likely to fall? And so we did a study a number of years ago now. We looked at 177 older people with cognitive impairment and dementia. A lot of information gathered at baseline, very detailed physical and cognitive battery, and we followed these individuals up for 1 year. And the bottom line is, and I've just summarized 4 years of a PhD into 3 minutes, so please appreciate that. The bottom line is, in terms of what are the independent predictors of risk in this population, it's really balance and a measure of mood, which was the geriatric depression scale. So in terms of conclusions from that particular study, we felt that physiological performance is an important determinant of falls risk, but we also know that balance and mood are potentially amenable to intervention. And predominantly an exercise intervention for both of those. Cognitive performance didn't seem to be an independent predictor in terms of working out who's most likely to fall. And for us, the next step is then to move on and pilot an approach to intervention. And we undertook a couple of pilots. The first one was really just to see whether we could engage with people with dementia and their carers, of course, to deliver an intervention. And then the second pilot was actually, can we impact on those identified risk factors, particularly that measure of balance? So the first pilot study we undertook over a 12-week period. So we did it as a randomized controlled trial, but it was a feasibility study, a combination of an exercise and home hazard reduction program. So undertaken with physiotherapists and occupational therapists working hand in hand with the participant and their carer, with a number of visits to home and also some telephone support visits. And what we did see reassuringly is actually we could get people to do a little bit more in the way of physical activity. So these are hours per week of physical activity. The control group did nothing additional. The intervention group certainly were doing a little bit more. So they were doing more, they were undertaking some of the modifications, so about 50% adherence to the modifications that were recommended. And importantly here, we weren't causing increased carer stress. We're very cognizant of asking carers to get people to do exercises, but that didn't, and also home modifications, that didn't seem to impact on carer stress levels, so reassuring. And falls rates seem to be going in the right direction, but the pilot study was absolutely not powered to look at falls. We just couldn't help ourselves. In terms of lessons learned, and we learned an awful lot from this, delivering OT and physio interventions over a 12-week period was overwhelming for the participant and their carer. From the physio's perspective, it was very difficult to actually progress the exercises over a relatively short period of time. And there was acknowledgement both by physios and OTs of the need to be flexible. Life happens to these people. They've often got outpatients appointments. They end up getting admitted to hospital intermittently. There was also a belief that we actually needed to understand the cognitive strengths of each of the individuals. So everybody with cognitive impairment or dementia has different cognitive strengths, and the way that you interact with them almost certainly needs to be adapted based on knowledge of their cognitive strengths. So we learned from that, and we did the second pilot study, and that was very much about, can we modify their risk factors? And we were looking to see whether exercise could modify both their balance and their measure of mood. So this time over 26 weeks rather than 12 weeks, and then exercise visits for the physiotherapist, and then support phone calls. So did we impact in terms of our measures? Well, the important measures for us were measures of balance, and yes, we were able to improve measures of balance. We also significantly improved their falls efficacy scale, and they were doing more exercise. Perhaps alarmingly, their strength, however, went down. So maybe we need to think about how we make sure we're doing enough strength and balance training. And I guess strength training is good in relation to mood. So we didn't impact significantly on mood. The GDS here at baseline was 2, the median score at follow-up was 1, so there was an improvement, but is not statistically significant. Now, at the same time as we finished our pilots, the Finnish study, Finalex study, came out. And this is an important study, and I would certainly recommend those of you interested in this area read it. Its purpose wasn't specifically to prevent falls. It was looking at the effects of an intense and long-term exercise program on physical function. And they selected a group of people who had Alzheimer's disease. So they were very specific in terms of the dementia selected as well. So it was a multi-center study in Finland, 210 community dwelling older people, age 65 and above. They had to be able to walk independently. And in Finland, they have a drug reimbursement register. So they're able to identify people who are on treatments for Alzheimer's disease. This is an important slide because it tells you how intense this intervention was. So the home exercise, and for the physios there, have a look and see whether you think that's something that is sustainable in a New South Wales or even Australian context. So home exercise, these are by highly trained therapists, 1 hour, twice a week for 12 months. You might have been allocated to the group exercise, which meant you came to what is equivalent to a day hospital. You still had 1 hour twice a week for 1 year. That was part of a 4-hour day centre visit, and the groups were approximately 10 people. The control group got that well-known placebo written information, and they were assessed at baseline, 3, 6, and 12 months. And their primary outcome measures were not measures of falls. They were FIM and short this. So the FIM is the functional independence measure, and the short physical performance battery. So this was about trying to improve function. So here's what happens. So over here, we have the total FIM score. And what you want to see in terms of your function over time is you want to see your function improve. And that is not what happened over the 12-month period. So what you'll see with all 3 groups is that they declined functionally, both in terms of motor and cognitive scores. What you will also see, however, is that the rate of decline was less in the group who were undertaking the home-based exercise intervention, followed by the group-based intervention. So where you saw the most decline was in the control group. So that's striking data. Even with that amount of exercise, these people decline functionally quite markedly over a period of a year. So the falls was actually just a secondary outcome measure, but they were very effective in being able to reduce falls in this particular population. So that's an important study. We moved on to have a look and see, with a big randomized control trial, can a professionally prescribed care-assisted exercise program, exercise and home hazard reduction program, reduce falls in people with cognitive impairment and dementia. So rate of falls was our primary outcome measure, and we had a range of secondary outcome measures. And right from the beginning, we felt that it was important to have a knowledge of people's preserved cognitive ability so that we could hopefully interact more effectively with them. There are different ways that you can assess people's preserved cognitive abilities. We chose to use the Allen's cognitive disability model. It's been around since the 1960s and is fairly structured and objective in its measures. The first part of the Allen's cognitive level is actually to undertake the leather lacing task. And here the individual is given a large piece of leather with some stitches already started. So this is just the ordinary running stitch. The individual is asked to carry that on. They're then asked to do a slightly more complex stitch, which is the whip stitch, and then a very much more complex stitch was the Cordovan stitch. And during that activity, the occupational therapist, who's been trained in being able to undertake the Allen's cognitive screen, watches the individual and looks at how they perform. Can they actually do the task? Can they identify when they've made mistakes? Are they able to correct the mistakes? Are they able to recognize that they can turn the lever over to see where the mistakes are? Do they seek help? So there's an awful lot of information that is just gained by watching the person undertake that task. And then having undertaken that task, there is a validation of the exercise, and we used two particular types of tests. There was actually the placemat, where the individual is given a piece of linen, some pre-cut shapes and some glue, and they're asked to replicate this particular pattern, or we give them a blank piece of card with some ribbon, and they're asked to replicate these. And at the end of that, you're able to assign an Allen's cognitive level, and that also then is able to guide how you interact with that individual. So let me give you a couple of examples. So a large Allen's cognitive level of 5 is pretty good, and this is Catherine, she's 88. Her ACER is 76, so evidence of impairment. FAB is 13, no falls in the last 12 months. She's got evidence of poor knee extension strength, and her balance is poor. She took 25 minutes to do the ribbon card test. She didn't require a demonstration. She was able to copy. She could see the front and back of the card. She could recognize the errors, but she didn't always seek assistance. But she performed pretty well. So in terms of a physio delivering that exercise intervention, so there was recommendations that the carer initially provide some assistance and supervision for Catherine undertaking the exercises, but very much a belief that Catherine would then learn those exercises and potentially be able to carry on doing those exercises herself. When her exercises were changed or progressed, then increased supervision would be required, and Catherine was still at a level where she could follow information both in the written form and pictorial form. Norman is very different, certainly performs at a much lower level, lives with his wife, he's cognitively more impaired, falls regularly, very impulsive, but again, potential to improve both strength and balance. He didn't do terribly well on the placemat, as you can see. And you could suggest that actually men don't particularly like doing stitches, but Norman was a tailor. He didn't refer to the sample, he had no depth perception. Instead of rotating the shapes, he rotated himself, and at one stage nearly fell off the chair doing the task. So he's very different to Catherine. So he's somebody who really, it's simple one-step instructions. He has to exercise in a very quiet area, no TV, no radio, no distractions. He won't have a perception of risk. He'll take a lot longer to do a task, and he'll certainly take a lot longer to habituate to doing the task as well. So rather than give him lots of new exercises, all we wanted to do was to be able to increase the intensity of maybe 1 or 2 exercises. So a very different approach. So in terms of the study overview, having suggested to you the importance of looking at cognitive ability in intervening, this exercise intervention with home hazard reduction went over a period of 12 months, 11 visits, pretty much half-half in terms of physio-OT, slightly more physio, but that was adaptable based on the individual participants that we were seeing. And here's what the groups look like. So 153 in the intervention group, 156 in the control group. Pretty similar in terms of age group, and in cognitive abilities, and they certainly were impaired. This is the mini ACE, so fairly similar to the MMSE, so they very definitely were an impaired group of individuals. Slight differences in terms of self-reported diagnosis of dementia at baseline, and also slight differences in GDS, which we adjusted for at the end. So, did we make a difference? This is our primary outcome, the incidence rate. So that's the rate of falls over the 1-year period, and no, we did not make a difference. If anything, a 5% increase in the falls group. But when you adjust for those differences in baseline, you'll see a 22% reduction in the intervention group, but that is not statistically significant. Where we do see some statistical significant differences is in the number of multiple fallers. And again, this is adjusted for the differences in baseline. So a 27% reduction that is statistically significant. So we seem to be impacting on multiple fallers, but not rate of falls. We also did a number of pre-planned analyses, and cognitive ability didn't seem to impact on whether you benefited from the intervention or not. But what did seem to make a big difference was how you performed at baseline from a physical perspective. So this is largely the PPA. And if you were one of those individuals who functioned better at baseline, you had a 55% reduction in falls. Whereas if you're delivering this intervention to individuals whose baseline physical function is very poor, you increase their risk of falls. No real difference in the rest of our secondary outcome measures. So of course, disappointing. There is some positive messages in there, but overall for the primary outcome measure, we didn't make a difference. So why didn't it work? Well, we initially intended to get 360 participants, but were unable to get that. It was a hard study to do. Adherence, so were people actually doing it? The exercises, well, the adherence rates both to OT and to the physio interventions were about 60 to 70%. So not bad, but we're doing more work looking at adherence. Care engagement in this study was absolutely critical, and the therapists say that where the carer was a live-in carer rather than a son or daughter who visited, they were probably the ones more likely to benefit. But again, we're still looking at that at the moment. This question of intensity is really important. And this was not a terribly intense intervention. It was delivered 11 visits over 12 months. It's very different to the Finalex study. Maybe it's the wrong intervention. Maybe it's too complex for this group of individuals, or maybe we should be just looking in the future at those who start off being physically better. We might need to think differently about the people who are physically poorer. Maybe putting them through a low intensity exercise and home hazard reduction program is the wrong thing to do. There's a piece of work that is looking further in terms of this question around intensity. It's a feasibility study being run in the UK. It's still going at the moment, and they are comparing an intervention that goes over 3 months versus an intense program over 12 months. So hopefully we'll have a better feel for the importance of intensity. And my gut feel is intensity is important in terms of this type of intervention. So I'm going to just finish in the last few minutes by moving to the more positive side. So just because we haven't successfully demonstrated through this trial that we can prevent falls in this population, it still doesn't mean to say we shouldn't do anything. There are very definitely things that we can do at this point in time to assist with reducing falls and fall-related injuries in people with dementia. So if somebody has cataracts, even if they have dementia, we would have every belief that they would benefit, first of all, in terms of improved vision and improved quality of life, but there's no reason to suggest that they wouldn't benefit from a fall prevention perspective as well. There's lots of evidence out there for vitamin D. Now, vitamin D is the benefits of vitamin D are in people who are vitamin D deficient. Most of those people reside in residential aged care. So if you did nothing tomorrow, or in terms of nothing else tomorrow, apart from starting people on vitamin D in residential aged care, you will deliver benefits. But there are also a lot of people in the community, particularly now, who are largely housebound, and they will also have the potential to benefit from vitamin D. People who are on centrally acting medications, older people with dementia are more likely to be on centrally acting medications. So again, good medical and pharmacy interventions in terms of reducing prescriptions of these drugs is important. Footwear and foot care, again, with dementia, why wouldn't you look at good footwear and good foot care? absolutely treat osteoporosis. These people are more likely to fall, they're more likely to fracture. There's no reason to suggest that these drugs for osteoporosis work any differently just because you have cognitive impairment. So we should be out there case finding, putting people who've had low trauma fractures on treatments for which we know they will benefit. So I'm going to conclude by suggesting that the people with dementia remain an important and high-risk group in terms of both falls and fall-related injuries, and the impact of falls and fall-related injuries on this population are huge. I think exercise probably is effective in the higher functioning individuals, but I think we have to get the dose or the intensity right. It is perfectly possible at this point in time to extrapolate from trials shown effective interventions in cognitively intact individuals, that we should be applying some of these interventions to cognitively impaired people, and they're certainly a high priority group in terms of treating osteoporosis. And again, as I get older, I keep thinking to myself, is measuring falls the right outcome for this population? Is it more about trying to preserve function and keep them at home? And is just preventing falls really what we're trying to achieve? I don't have the right answer. I think if you ask most older people what their priorities are in life, most of them don't have falls prevention as their number one priority. They normally will say, I want to stay at home, I want to remain independent for as long as I can. So I think probably we should be looking at preserving function, and hopefully preventing falls is a secondary successful outcome measure from that. Thank you very much.